And today she's going to talk about this study, which is extremely interesting. And I would like to say she does hold a chair in women's health in the faculty, in the Bloomberg Faculty of Nursing, and is also at St. Michael's Hospital, where I think this is where this research is being carried out, right? In the, what's it called?
Li Ka-shing Knowledge
The Lai King-shing Knowledge Institute.
Oh, no.
Here she is.
Okay, so I'm going to, talk about the POWER study, but really put it in the whole concept of assessing quality and outcomes of care for older adults, and what some of our findings are telling us about, what we need to do here in Ontario, what some of the issues are in terms of, caring for older adults in general, and also women in particular, and addressing some of the gender and equity differences. So basically, to start, I'm going to say, what is quality? So quality is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. And we know there's a quality chasm. There's a huge gap between the quality that we have and what we know we can achieve. And basically this was a landmark report from the Institute of Medicine, probably almost a decade ago now. But basically what they concluded was that there are serious problems in quality between the healthcare we have and the healthcare we could have. Lies not just a gap but a chasm. And the problem comes from poor systems, not bad people, and we can fix it, but what really requires more systems level and organizational interventions. As hard as we try as practitioners, we're not going to fix it unless we work to transform the system around us. And we know there's a quality gap. Similar studies have been done in Ontario. Again, a landmark study by Beth McGlynn that was in the New England Journal of Medicine basically said that when she did massive chart reviews across the U.S., half of people received indicated interventions. But it gets even worse because the ACOVE study, which is assessing care of vulnerable elders, found that actually adherence to quality indicators was lower for geriatric conditions. So as bad as we do in terms of prevention and chronic disease management, we do even worse in practice managing geriatric syndromes and conditions. And for those, it was 31% compared to 52% who had received the indicated interventions. And those are things that we know about: incontinence, falls, dementia, etc. But they did another interesting analysis from the ACOVE study, which is one of the few studies that actually shows that quality of care makes a difference. What they found was that those people who had higher quality scores actually had higher survival. So it really gives, the evidence. And actually, I was thinking I should have put in a slide on this too, because I had a paper in Medical Care last month where we looked at the performance of the quality of care for diabetes at the health plan level on performance indicators and its relationship to two-year functional health outcomes, and found that quality of life was better among older diabetics who had better quality of care. So for a long time, people said, well, do quality indicators really make a difference? But I think there's growing evidence, even though it's slim, that it actually does. And that we know in terms of prevention that, our goal is really to compress morbidity, right? We want people to be active, independent, age at home, live to be 120, and then go to bed and die, right? So, and this is from the Physicians' Health Study, which shows that it really is indeed possible to compress morbidity. Because what they found was that the probability of a 72-year-old to reach age 90 was 54%. If they didn't have 5 risk factors, all of which are modifiable: smoking, diabetes, obesity, hypertension, and sedentary lifestyle. And if you had 5 of these factors present, your chance was 4%. So that's a huge difference in terms of, I guess there's some tough people out there who can abuse their bodies and still survive. But also the physicians with longer lifespans and fewer risk factors also had delayed occurrence of cancer and heart disease, because we know all these things are also risk factors for that. And they also gained relative disease and disability-free years. So it made it, both the length of their life and the quality of their life was impacted. So I'm going to switch now and talk a little bit about, with that context of quality measurement and improvement, what we're doing with the power study, because what we're really trying to do is create a tool for monitoring and improvement. And we know there's growing evidence that performance measurement and reporting can be used to drive both health systems improvement and health equity. But we also know that quality improvements can narrow, maintain, or widen inequities in health and health care, whether they're associated with gender, income, race, etc., and that the overall performance improvement can mask inequities. So there's a lot of work going on in the province now doing all kinds of performance measurement, but if we don't look at subgroups separately, we're going to miss the opportunity to improve care, and particularly older women are vulnerable. That's a consistent finding that we've had. So the Project for an Ontario Women's Health Evidence-Based Report is designed to serve as a tool to help policymakers and providers improve the health and reduce inequities among women in Ontario. So the overarching objectives of the study is the use of performance measurement and reporting, both as a mechanism for knowledge translation. So we're really doing this to raise awareness of some of the gaps in practice and stimulate interventions, but also as a tool to drive equity in healthcare. And what we're doing is providing evidence for use by a diverse group of stakeholders for use to improve women's and men's health in the province, because the truth is we did gender differences, so we actually have the data on men's health, and I think our findings consistently show how important it is to look at gender and gender sex disaggregate the data, because men and women have different issues and there's different opportunities and levers for improvement and different needs. But the other thing we know is that reporting by itself does not result in improvement. So there's some people who still believe this, that all you have to do is show people how they're doing, and they say, oh, I want to get an A, and they're going to fix everything. It doesn't happen. So for performance measurement and reporting to result in change, it needs to be evidence-based, strategy-driven, linked to a commitment for change by health system leaders and providers and mechanisms of accountability. And I'm not going to, for this group, I don't think I need to spend time on it, but it's really important because men and women are very different. They have different patterns of illness, morbidity, mortality, different social contexts, and different experiences with health care. And actually, it's a women's health report, but the reality is that the differences in health among women associated with socioeconomic status, ethnicity, etc., are much greater than the differences between men and women overall. So it's really important not just to look at women's health, but to look at the diversity of health among different subgroups of women. And this slide just shows why it's important. Basically shows single parent family income is increasing, and then the bottom says single parent family income gender disaggregated, which shows that men's income has been going up while women's has been going down. So if we don't stratify, we can miss important differences. So basically what our project is doing is really developing a model for incorporating gender and equity as an integral component of improvement efforts. And also the other thing we're doing that's a little different is focusing on the need to integrate efforts to improve both population and healthcare services. So there's a big divide, and there's a lot of innovation going on in both those sectors, but they don't work together. And clearly we need prevention on a population level. We need to address the social determinants of health, but we also have to improve healthcare services and quality and patient-centeredness, particularly for older adults and older women. And also we're doing, helping to build the evidence base about some of the pathways and factors that contribute to these findings. Even though it's a very quantitative study, you see we've used a lot of data, a lot of big secondary data sets in the province. We've developed it as a community-engaged research project and model. So what we did was we really engaged a wide diversity of stakeholders from the beginning to inform what are the issues, what's important to measure, showing people our preliminary data, what does this mean, what is the messaging, and so also it's really serving to help the knowledge translation component now that we're out and released, because people are aware of it and are using our data for a whole host of purposes. And we engaged a whole range of consumers, providers, and policymakers in our stakeholder engagement and consultations. So basically, what was the overall method for this study? We did a systematic review of peer-reviewed and gray literature to identify previously validated indicators across the continuum of care. We did a series of 8 content-specific technical expert panels using a modified Delphi process to select a comprehensive set of indicators for reporting. We had specific indicator selection criteria. And then indicators were measured using multiple secondary data sources, including survey data, administrative data, disease registry data, and vital statistics data. And indicators were first stratified by sex and then by income, education, and ethnicity as data source allowed, first at the provincial and then at the level of Ontario's 14 local health integration networks. So basically what we've done that's a little different, there's a lot of women's health reports that look at men and women. There's a lot of reports that look at, social determinants of health and look at income, education, etc. But what we did was we stratified all our indicators first by sex and then by income, education, ethnicity. So you could see that interaction between these factors and gender because they do influence men and women differently. The report's being released in 2 volumes. The first volume chapters burden of illness, cancer, depression, cardiovascular disease, and access to healthcare have all been released, and they're all available for download on our website. They're very long, so if your eyes glaze over when you see them, we've also prepared an 8-page highlights document. So if you just want to look at that, that's easier if you want to get the take-home messages and the key findings. And as the spring comes up, we're going to start releasing the second round, which are on diabetes, HIV infection, musculoskeletal disorders, reproductive and gynecological health, and special populations and the social determinants of health. And in the special populations group, we are going to have a focus on older women in that. So, multiple uses for the study, priority setting, informing policy and practice. It's a tool for improvement. It's a tool for integrating equity into planning and quality improvement. And of course, we're doing research and building the evidence base. Before I show you our findings, I want to just step back and show you a few frameworks just to think about the bigger picture of the findings. And then I'm going to show you some background information on performance measurement and improvement. And then I'm going to show you some of the results. And I try to pull out some of the findings particularly related to age, because age is a huge issue in terms of healthcare delivery. So this is an old framework. Some of you might have seen this before, but I think it's important just to kind of show it again because it really was developed to inform research agenda on health services, research and aging. And it was a consensus model where we decided that the most important outcome for older people is physical function, is functioning, all the different domains, physical, cognitive, emotional, role, social, and that where we focus mostly in terms of improvement is on clinical practice in the individual patient, but there's a lot going on around that. So there's community and family factors, there is biology and genetics, but also it's influenced by how we pay for care, how we organize it, and policy shapes this. So policies can really have a good beneficial or unintended consequences in terms of affecting health outcomes. And so that we really need the evidence for policy interventions the same way we need the evidence for clinical interventions in terms of what is it doing in terms of, impacting on health. We developed a women's health indicator framework for the study, which basically we all know that the non-medical determinants of health are the primary drivers of health status, but how we organize community services as well as the health system can mediate that. So we can either exacerbate or minimize the inequities. And then gender is always listed as a determinant of health, but in reality it interacts with all of the determinants. So it's more complicated than that. And then we just created it into a pretty picture that you could download. It's harder to read as a slide, but it's prettier, and you can download the framework from our website. The other thing in terms of thinking about access, quality, and outcomes, last week we actually released the Access to Care chapter where we really identified lots of barriers to care for different subgroups in the population here in Ontario. So to think about access is to think about the different dimensions of access, and this framework is really used to identify levers for interventions within a health system. So you think about primary care, primary access is can you get in? So, is there a provider in your community? Do you have transportation? Even here in Ontario, there's people who don't have coverage because either they're undocumented or they're new immigrants and they're in the wait period, or they might have insurance but not have access to, drug coverage or things that they need to get their services. So that's primary access. Secondary access is the barriers within the system. So you have a primary care doctor, but you can't get an appointment, you can't get advice after hours, you can't get a timely referral to a specialist. And we found quite a few secondary barriers within our system. So people have, for the most part, people do have primary care doctors in the province. There is about 7% who don't, but they're not always getting what they need from those doctors. So that's the second challenge, is fixing those structural barriers. But the tertiary access, I think, is particularly important for older adults, is the ability of a provider to address patient needs. So is a provider aware of conditions and functional limitations? Do they have the skill set to manage geriatric issues? Do they have the requisite knowledge and skills, and also cultural competence? I mean, I know a lot of people here are doing work in the center on the diversity of the aging population, and there's different needs and different cultural sensitivities that have to be incorporated into care for different populations. And I'm not going to spend a lot of time on this, but I just want to acknowledge how complicated it is, right? So, we tend to simplify things, but this is sort of looking at a framework for health outcomes among immigrant women, to think that there's issues that went on in their country of origin in terms of their individual level factors, their income, their education, their beliefs, the community characteristics there, the type of country, macro level factors at the national level in that country. What were the factors that determine somebody to move? And then when they get here, there's all these different levels operating. So, we can only deal with one thing at a time, but it's important, I think, to look at the complexity of the determinants of health and how they all interact in the multiple levels in terms of thinking about different partnerships across sectors to really optimize health outcomes. And this is a book that actually came out like 2 years ago, which I highly recommend, by my colleague Chloe Bird, who developed this model of constrained choices. Because, we tend to find that people who are disadvantaged tend to have worse health behaviors, and we say, oh, if they would just, lose weight and exercise. But the fact how our social context influences our choices and our ability to do things, and the need to tackle those to really improve health and support people in terms of having healthy lifestyle. So this framework that's part of that book it just talks about constrained choices. And just to think about more and more, especially older people, where sometimes it's not clear what the right decision is. I know people here work, with older populations and know this, but more and more how patients are really key in terms of optimizing health outcomes, and that, patients are really co-producers of health in a whole set of ways. They're participants in their care, especially chronic diseases, self-management, involvement in chronic care, lifestyle choices. They're decision makers in terms of choosing where they go, what medicines they're going to take, when they're going to go for care. But they're also evaluators, and more reporting on their experiences of care. And I'm not going to talk a lot about it today in the power study, but we did look at people's perceptions of difficulties getting care and their experiences with care and their satisfaction. Actually, older people tend to be more satisfied. I think as the baby boomers hit the over 65 years, this is going to change, and people are going to be more demanding, and you're not going to see that as much. And just to say that we do have evidence for different models of care that actually can improve health outcomes. And I think the biggest contributors to disability with aging are chronic diseases, most of which are preventable, or the adverse sequela are also preventable. And the chronic care model is very well known, developed by Ed Wagner in Seattle, Washington. And Virginia Barr out in Victoria expanded on the community side of it, which I really like. So his model basically had the elements within a health system, what you need to do to optimize chronic disease care. And it's things like good information systems to coordinate care, decision support, delivery system redesign to become more proactive, and really work with patients on developing self-management skills. And then what he said is that really to optimize health outcomes, you need an informed, activated patient and a prepared, proactive practice team. And I always liked his model because it included community, and what Virginia Barr did was expand that community piece of it. So what she did was put together the need to build healthy public policy, to create supportive environments, to strengthen community action, and then put that activated community and prepared community, proactive community partners kind of around the clinical practice to integrate it. So I think as you start looking at the results, kind of think about, well, what does this mean in terms of the way we organize and deliver care? I'm going to give a little background on performance measurement and change, and then go on to the power study findings. But this is pretty much it. If it gets measured, it gets done. So I think measurement can be a valuable tool. It could be also dangerous if we're measuring the wrong things, right? Or setting the wrong priorities. But it really can be powerful. And there's multiple uses for quality measures: for improvement, for accountability. They're included in the hospital agreements, the WIN accountability agreements. They're more and more being used across the province. Not so much here in Ontario, but in other places they're used for choice with public reporting. You could pick your provider or your health plan or your hospital based on how well they're doing. There actually is now some reporting of wait times and patient safety by the Ministry of Health at the hospital level, and the OHA is reporting some hospital level data on performance too. So it is coming here. For equity, which is a big focus of my work, and also now more and more for evaluation. Are the interventions we're doing moving these indicators? And this was a very nice editorial that was in the New England Journal of Medicine a few years ago, and it was called Eulogy for a Quality Measure. And this was beta blockers after MI, because actually it was retired that year, this measure, because performance was consistently over 90% everywhere. So there was no more need for the measure. But what they did was they raised the bar. The new measure is that you still have to be on them, not when you go at it from the hospital, but 6 months later. So it gets that integration of care between inpatient and outpatient. But what I want to just show you from the slide is that originally there were people up at the 90th percentile, and they were doing just fine. But look at the spread in performance. Look at where people, providers in the 10th percentile were. They were down around a third of people were getting it. So what happened over time is the people who were up in the 90th percentile kind of slowly got better, but the people in the 10th percentile really improved in it, and it kind of made practice more consistent. So I think by strategically selecting the right measures, you could actually improve care. And we know that beta blockers is an important measure because it reduces mortality, basically, after MI. And this slide, I just wanted to show the importance of disaggregated data. This is by race and ethnicity. And this was a paper by Trivedi that was in the New England Journal of Medicine looking at managed care data from the U.S. So what he found was, if you look over here, the first slide was whether people had their cholesterol checked with diabetes. And you can see that over years, this was a quality indicator, the performance improved, and it improves for both blacks and whites, and the disparity reduced. So that's what you would like to happen. But the other slide looked at whether your lipids were actually controlled. And so what happened was they actually improved for whites and they improved for blacks, but they improved faster for whites and for blacks. So actually the inequity actually increased. And I think this kind of illustrates 2 points. One is that you can improve care and not necessarily equally improve it for all populations, but also it's much easier to improve process measures and outcomes measures. Because if you want to start moving outcomes measures, you need to start looking at all the factors that influence health outcomes. This is some work I did in the States looking at the interaction between gender and race. And this was looking at that same indicator, lipid control and health plans. And basically showed, if you look at the top box, right, that's white men. They had the highest rate of control. If you went down, that was white women, and then black men were just around the same as white women, but black women were even more disadvantaged. And we're finding that here in the province where there's a real interaction between ethnicity as well as with income for a lot of the indicators that we're doing. And just if you look at this slide here, you can see that it varied, the pattern varied for different indicators. So you can't, it's not a consistent pattern. You really need to know what the condition is and what's going on under that. So, but we also have to be careful because older people, sometimes it doesn't work for them. So if you, this was, Boyd did this was in JAMA back in 2005, but what she did was she took a hypothetical older patient with multiple chronic conditions and figured out what would happen if they adhered to every single guideline for every condition, what the implications would be. So she concluded that adhering to clinical practice guidelines and caring for older persons with multiple comorbidities may have undesirable effects, and that basing standards on quality of care and pay for performance on existing guidelines could lead to inappropriate care. And what she calculated that a 79-year-old female with 5 chronic conditions would end up being on 12 medications, costing $400 a month, and having potentially adverse interactions. So it's not trivial. So I'm advocating, quality measurement, but we need to be smart about it. And as we get into older adults, it gets more and more challenging because of these issues of complexity, frailty, end of life. And people are working on this. I think there are strategies to deal with this, and they're going to get better. But we need to keep that in mind as we start looking for care. Anyway, and also there could be unintended consequences of publicly reporting quality information. People could stay away from, you don't want to do that, you're too sick, I'm not going to take care of you, I'll take care of healthy people. So risk selection avoidance of sicker patients. There could be inappropriate screening or treatment. Did you get your screening for colon cancer or mammography when your life expectancy is shorter than what would benefit? So it just gets more difficult. And discounting patient preference and clinical judgment. Like people might have good reasons not to, take a certain treatment or etc. And there might be other clinical reasons not to do that. There actually was a nice paper, I think it was last month in the Annals of Internal Medicine, where they did a trial. They actually do this in the UK where they allow physicians to make exceptions. So this was in one academic health center, and they had doctors were able to enter in why they were not giving the beta blocker or, whatever was indicated. And they found out that in 96% of the time it was correct. That's in this one practice setting. It might be different in other practice settings, but I think there could be ways to address complexity. So now I'm going to show you some of the findings. This is Ontario data. I know I've been here before showing U.S. data, but this time this is all local. So this data, this is the overall population. I didn't bring this stratified by age, but I just wanted to show you what surprised us with this finding was not that there's disparities in health status in the province, but how big they were. So this is age-adjusted. But basically, a quarter of low-income men and women reported fair or poor health compared to 7 and 8% of. So there's a threefold difference, and it's huge. I mean, we calculated that probably about 250,000 fewer people would be fair or poor health if everybody had the same health as the highest income group. So this is a big impact. And then also that there's huge differences by ethnicity. We don't do a good job of collecting ethnicity data, but the data we have shows how important it is to get this data. And if you look here, 29% of Aboriginal women reported fair or poor health, compared to 12% of white women. So there's huge differences by ethnicity. And the other thing is that the gender effect also varies by ethnicity. And then also language is also an important factor in terms of health status. where we looked at francophones in the province, and here over 20% reported fair or poor health compared to those who spoke English or French. It was twice as likely to report fair or poor health. And those who don't speak either English or French also reported worse health status. So to start thinking about the dimensions that influence access and health outcomes. Now this is, I'm going to show you the prevalence of some common chronic conditions, and this is stratified by age and income. So this is arthritis, which I think is one of the, it somehow gets neglected, but there's a lot we can do for it in terms of pain management, increasing physical functioning. And you can see here that women are twice as likely as men across all age groups to have arthritis. Just so you can orient you, this is women age 25 to 64, women over age 65, men 25 to 64, and then 65 plus. And you can see there's an income gradient, and 2/3 of low-income women and half of higher-income women over the age of 65 are reporting arthritis. Now, this is hypertension. Again, women are more likely to have hypertension than men. And again, you see the same income gradient and just the huge burden of illness associated with age. And this is having heart disease or stroke. So men are a little bit more likely to have it, but look at the income gradient among women. So 1/4 of low-income women report heart disease and stroke in the two lowest income groups compared to 13% of women in the highest. That's in the over 65 population. So just to think about it, the people with the highest burden of illness are the people who have the least resources to, negotiate the system, and maybe the least resources to kind of meet their needs outside of things that are not covered. And then this is diabetes, another common chronic condition. The province has a diabetes strategy now, and nearly 1 in 5 women, low-income women over the age of 65, have diabetes. So it's a big problem. And the other thing is, we tend to, say, oh, heart disease is a problem, or osteoporosis is a problem, or diabetes, and we come up with strategies, and they're all really important. But the problem is that once you get to 65, let me turn that off. Sorry about that. Most people have multiple chronic conditions. So this is stratified by age, so you can see the income gradient for both men and women in terms of having 2 or more chronic conditions. And these are important ones. These are things like diabetes, stroke, arthritis, hypertension. But if you look at 70% of low-income women have 2 or more chronic conditions. So the real need for patient-centered care, for integrated care, for care that really addresses, multiple health needs. And then this is, kind of sometimes trying to find levers for intervention. This is the percent of adults who reported that their activities were prevented due to pain or discomfort. So there's been a lot of focus on pain management in hospital settings, but not so much in community settings. And if you think about aging at home or keeping people independent in the community, managing pain is quite important. And if you look over here, 35%, over 1/3 of low-income women age 65 and older in the community are reporting that their activities are limited by pain. And look at the income gradient. And we don't know, we need to do more studies, but is that suboptimal care in terms of pain management, or is it more severe disease? And to what extent can we optimize it? But I think this is a huge, huge opportunity for improvement. And the way we saw doing this is we basically looked at a lot of indicators for this project, because we didn't know where the gaps were, and we didn't know where the needs were in the province. And now that we have these, we're hoping to engage people in identifying a core set of smaller number of indicators that are modifiable, that we could track going forward. And I think this would be a great candidate in terms of improving older women's health. And now I'm going to talk a little bit, our access to care chapter actually has a lot of indicators on, access to primary care and chronic disease care. I'm just going to focus on one of the indicators, one group of indicators from the study, which is avoidable hospitalizations, because I think this is really key to health system sustainability. And what ambulatory care-sensitive conditions are there conditions that, if they're well managed, that many of the hospitalizations could be avoided. So these are things like heart failure, diabetes, emphysema, asthma. And I'll just show you some of the findings here. This is the income gradient. So we know there was a huge difference associated by income in terms of who was admitted for these conditions. This is heart failure. Here, men actually tended to have more hospitalizations than women. Actually, women were more likely to be readmitted once they are admitted. So there's differences there. But if you look at this slide, look at the age distribution. Heart failure is the disease of the elderly. So look at the rate in those over 80, and we know what happens when they're admitted to the hospital. So if we want to improve heart failure management, it really needs to incorporate, a geriatric focus. And then I have some pie charts here, which basically show among women, over 90% of the hospitalizations are for heart failure in those age 65 and older. So it really is a disease of aging. This is emphysema, shows the same pattern. And again, look at the age-related rates of hospitalization for emphysema. And diabetes, again, more admissions among younger people because, there's 2 types of diabetes, so there are younger people who are admitted. But look, the bulk of the hospitalizations also, even for this condition, are in those over age 65. So actually, we did some back-of-the-envelope calculations, and we calculated that if we could reduce in the lower income groups to the rate of the highest income quintile neighborhoods, we could reduce 9,000 hospitalizations a year in the province. And then we also did Lynn level. There's lots of variation. There's a lot of regional variation on all of these indicators. So if everybody could perform at the rate of the best Lynn with the lowest rates for each of the conditions, it's about 8,500 hospitalizations on estimate that we could reduce. So there's a huge potential in terms of health system sustainability, in terms of better chronic disease management in the community for these conditions. And it really takes integrating primary care, community services.
Send me my question, what are the best ones doing?
What?
What are the best ones doing? So the best LINs.
Oh.
What's the differences in care that they're providing?
Well, that's the next thing, is to see what accounts for those differences, right?
Okay.
Right? We just have the different rates, but the performance in all of these indicators varies enormously across LINs. And some of it is resourcing, some of it is workforce, some of it is quality and delivery. So I think we actually, prior to releasing all of our data publicly, we hold a webinar with the LINs who are interested. And we provide them much more detailed data. Like, we don't put all of the different analyses in the report. They get all of their data, they get their p-values and confidence intervals, and they are able to compare to Ontario. And when you give it to people at the local level, there's probably different reasons in each of the LINs for the differences in performance, but they know, it resonates with them, and they know what the issues are. So, this is like high-level performance, and then to change things, it's drilling down in different communities. The interventions in different regions will probably be different. And so I have a few slides on cancer. I didn't put in cancer screening because mostly that occurs in younger people, but age is an extremely important determinant of treatment, and the complexity. So this is women who had, these are more clinical indicators now, but the percent of women who had breast cancer surgery who had an axillary lymph node dissection. And you can see, as people get older, we're less likely to use these interventions. And it becomes a big challenge to tease out, saying why we need more clinical data to be able to assess this, because there might be some clinical reasons. If somebody has competing demands for death and a shorter life expectancy, maybe you wouldn't do it. So there might be reasons for lower performance in the 80 plus, but we also know there's age bias, and we tend to undertreat people. So the complexity of it and the need to kind of pay attention to this and think about this in terms of delivering care. And again, this is whether somebody with rectal cancer was referred for radiation, basically to a radiation oncologist. And again, you see there's a huge age factor there. So we need more clinical information to see what's optimal and who should be getting this, and making sure that those who need it are actually referred. And I don't think we've really addressed the age issue as much as we need important too, especially with the aging population in the province. Oh, there. And this, so I showed, sort of diagnosis, which was a lymph node dissection. I showed radiation, and this is just a slide for chemotherapy for ovarian cancer. And again, there might be more contraindications in the 80 plus, but there also might be women who might benefit who are not receiving treatment. So we need to start understanding how age influences treatment choice. I'm going to show you a few slides from our chapter on depression. And basically, this is the percent of people who had depression, probable depression by a survey. This is from the Canadian Community Health Survey. And whether they actually had a physician visit. So we had linked data with the CCHS and OHIP files. And you can see that actually older people were a little bit more likely to see a doctor about their depression than younger people, but there's still a huge gap. About half of people who have depression are not getting treated or not, and this is consistent with the literature. I should say there's a limitation. They might have been seen in the community by a non-physician or some other sources, but it is consistent with the literature that a high number of people who actually do have depression are not receiving care for their depression. And then this, I think this data is, the absolute numbers might be a little higher, but we looked at, these are people age 66 and older who were started on a new course of antidepressants. And basically, it's recommended that you have 3 visits within 12 weeks to monitor response to therapy, side effects, etc. And we found a small income gradient, but we found like most people were not getting those 3 visits. So we need better data to make sure that that's the case, but I think we also have a huge way in terms of improving mental health care and chronic disease management. Now this I wanted to show you in terms of integration. Again, this isn't age specific, but I think the pattern is the same for older or younger adults. That basically we looked at whether you were admitted for depression, whether you saw a doctor within 30 days of going home from the hospital. A third of people didn't. And so when we looked at this for heart failure or MI, it's 99% everywhere for every group. So, it just shows like with mental health, we still have a ways to go in making those care transitions between hospital and home. So I think this is a big area for intervention. And then we've made lots of maps. You can find them on our website. But this just shows the percentage who got a visit by region, right? And so this is here, like Toronto Central is lighter, still performance wasn't great, but it was better. And you can see this ring around here, where like northeast, northwest, and southwest tend to have lower performance on a lot of indicators, and also worse health status. And then this is to show that basically they weren't being seen in an office. 20% of them were coming back to an emergency department, and about 8% were being readmitted within 30 days. So, in terms of reducing demand on emergency rooms, hospitals, this is a huge opportunity here. I'm going to show a few slides on cardiovascular disease. I hope I'm not overdosing on data here. I just have a few more slides just to make a few examples. These were the percent of people who were discharged from a hospital with heart failure, and this is a percent who were seen back in an emergency room within 30 days and within a year. So within 30 days, 30%, or nearly a third, are coming back to the ED. I think that's another place where we could probably have a huge target for intervention, and within a year, 75% are back in the emergency room.
Do you link any of this data to length of stay? I just keep thinking that it's such a process indicator we use for the elderly. Get them out.
Yeah.
But we don't.
No, we haven't done that. So, but I think CHF is a great target for intervention because it crosses primary care, hospital care transitions, and the other thing I think that's important here is the dark-colored bars here are non-heart failure related or non-cardiovascular disease related admissions. So how much is stuff that they get while in their hospital? They pick up an infection or, another issue or something else they have. The medication gets inadvertently stopped and gets out of control. So I think this also argues for the need for patient-centered care. So this was ED visits at 30 days in 1 year. And then we looked at readmissions. 20% are readmitted within 30 days and about 60% within a year. And again, about a third of those are non-cardiovascular admissions. And just to highlight, sort of one of the areas of sex differences, once you've had a heart attack, we know that if you go on a statin, it reduces your risk of a recurrent MI or death. And consistently across all the LINs, performance varied, but women were less likely to get a statin across LINs, than men. We've made a lot of improvements. The gaps in cardiovascular disease care have narrowed over the years, but they're still there, and we still need to go the rest of the way in terms of closing these gaps. And basically, this is angiography. One of the things, if you have a heart attack, a lot of people benefit from looking at their coronary arteries, and what we found were there were income and gender differences in angiography as well. And I put this in for age because, again, there might be reasons for it, but as people age, they were less likely to get angiography. So we need to do more to make sure we're making the right choices for people, and that those rates are right. I'm going to stop there maybe and just talk. Are there any questions about the data? Or? Okay. So there's lots of limitations to our study. We were limited to existing data. The CCH analyses use self-reported household income, while analysis using administrative data used neighborhood income quintiles. We still saw the same pattern. For this, most of our drug data is on people over 65. That's what we can report. But it's really important so we don't know what's going on with people under 65 who are not eligible for ODD in terms of chronic disease management. So that's a huge data gap. And there's also a lack of data on quality of care in primary care and ambulatory settings. So it's easy to kind of link the OHIP data to the ODB and see if people are getting beta blockers after an MI or after an admission for heart failure. We don't have that kind of comprehensive data in primary care. And I think to really know how we're doing, we need to develop that data. I think there's a number of other data challenges. We need core items for monitoring that don't change over time. A lot of the surveys, they keep changing the items. So if you really want to track things, for example, they no longer ask the pain item in the CCHS. And that's such a key indicator. So, how do we have a conversation about what's important to measure and what we need to continue measuring? Clearly we need data across the continuum of care. The richest data is hospital data, but we need primary care data, but we also need CCAC data. We need to know what's going on in all the different sectors. There's issues around data completeness and quality. And also in terms of ethnicity, I think it's a growing issue with the growing diversity of the province. The recent Stats Canada reports. In a lot of jurisdictions, they oversample minority groups, so you have the sample size to make estimates. We were able to look at ethnicity on some indicators and not others, but clearly we would have liked to have looked at it across a wider range of indicators. And again, one of the issues about measurement is that you measure what you have data for. So sometimes it could kind of be like looking for keys under the street lamp, right? And you could be missing other important things that are there. So we don't have any data on important domains like caregiving, which impacts on women's health, violence against women. So to think about what needs to be added to data so that we can capture some of these other issues that impact on health outcomes. So just basically, we kind of identified some data needs in Ontario wish list. But data on ethnicity, also in Some jurisdictions it's included in, will be included in OHIP data, or will be included in hospital data. People could self-identify. We need richer data on socioeconomic status. We need more gender-relevant measures, things like caregiving, etc. We need drug data on people under 65. We need primary care data. We need more information on clinical factors to tease out appropriateness in different settings, especially for older people. And there's lots of issues with the vital statistics data in the province. I'm not going to go there now. And each of our chapters, what we do is we identify some key messages for policymakers. And just I have for two of the different chapters, just to give you an example. So for example, on the burden of illness chapter, which looked at population health, the need to prioritize chronic disease prevention and management, the need to coordinate population health, community, and clinical responses. So there's a lot of work going on, and people are doing a lot of innovative, effective interventions, but they're all fragmented. And can we be more effective if we integrate and coordinate some of these? Clearly the need to address broader determinants of health. I think people get, everybody knows that, and it's harder to do, but I think we can't forget it. And I think there's opportunities for cross-sectoral collaboration to do that. But also I think all our findings consistently, highlight the need to routinely include gender and equity analysis in health indicator monitoring and reporting. So hopefully, we can encourage more people to sex and income disaggregate data as they do their health reports. And then this was, in terms of the cancer messages, was the need to reduce cancer-related health inequities by focusing on prevention and screening. But that, I won't go into that because I didn't present that data, but what came out clearly in the cancer chapter was the need to address unique needs of an aging population in cancer care. Like that was just so striking across all of the cancer chapters. So, there's a lot we can do. And I just sort of thought I would close by thinking about some of the different targets for intervention. So there's on multiple levels, on the patient level, the practice level, the health system level, the community level. We need to partner and more integrate health sector with human service providers, social service providers, and community-based organizations. And quality improvement, we need to also target and monitor disparities. And there needs to be advocacy for policy and cross-sectoral partnerships to address the social determinants of health. And in terms of moving towards equity in health, the need for prevention and health promotion, the need for health system redesign, particularly around chronic disease management and patient-centeredness. The need to, again, address the broader determinants of health, and then performance measurement and improvement in identifying the right indicators and reporting them in a way that looks at equity issues can really help improve care. But we do need to improve data capacity for measurement. And we have a lot of evidence now where the gaps are. Where we need the evidence now is what will close these gaps and what's effective and what works. Even in the literature, there's a paucity of evidence on what works to reduce or eliminate disparities. And I think as we go forward, as people are doing different interventions in different areas, we need to do them in a way where we can really effectively evaluate them to learn what works and what doesn't, and kind of accelerate our knowledge about how to address some of the issues that we found. So I'm going to close there and just let you know that everything is available on our website for download. So feel free, and if you have thoughts, ideas, comments, email us. We always welcome suggestions, feedback. Thank you.
Does anyone have any questions they'd like to ask?
I do. And I'm from the community involved in a variety of issues, and I've taught feminist courses, so I was intrigued with your focus. But I have some issues. One, I get very frustrated when people lump older people 65 plus. Very few of your slides had the breakdown between 65, 75, 75, let's say 85, and the older old. Because we don't really compare a child of 5 to a 20-year-old. but we tend to do it once you get into 65. And that troubles me because there are differences, quite significant differences. So was there a reason because of the lack of data that you had access to that made those age distinctions?
Well, I think part of it was just to, have fewer slides, but
Right.
because when I did try to pull out some slides where we did actually look
I saw that.
at 65 to 79,
Yeah.
80 plus, because I do think your point is very well taken, and that, it's a different population with different issues. We actually did, whenever the sample size allowed, sometimes you get into too small cells,
Sure.
that you don't have enough sample size, especially in the over 80 population. But wherever the sample size supported it, we actually did that.
Great.
And we actually have, we provide the LIMS, with their data that has the more finer breakdown. And eventually we're working to develop a web-based reporting interface where any strata that we're able to report will be there, so that if you're interested in the 80 plus and if you're interested in a finer breakdown, you'll be able to do that.
Oh, that's great. And one other thing, if I might,
Mm-hmm.
I'm old enough and have a long memory and study of public policy. We know that prevention and promotion work. No budgets go into it.
Mm-hmm.
The medical system, the healthcare system, has no incentive to go that route. No matter what study you look at that shows this, forget it. It doesn't happen. So what are you hoping for?
You know what, we're working very closely with policymakers and providers across the province, the Ministry of Health Promotion, the Ministry of Health,
Yeah.
the LINS. It is an age-old challenge, and clearly, I think, and the problem is that it's a long-term investment, right?
Oh, of course.
Because we need to invest in prevention now, but I think with the aging population, that's what we keep saying, is that the prevention and chronic disease management is really key to health system sustainability. You might have better ideas than I do in terms of how to get that implemented. I mean, that's an age-old problem.
Yeah, exactly.
I just came from another seminar in which they were pointing out that they had accountants do some cost and effective research. And once they were able to show government that they would save money by non-smoking legislation or by seatbelt legislation, everything changed. If you can show them the fact that the hard dollars apparently makes an enormous difference.
I wanted to ask, you mentioned caregiving. Are you considering these women as caregivers to others or caregivers for older women?
Oh, well, I think,
Because there probably is a huge difference, well, in both respects.
Mhm.
Women who are still have dependents or maybe even older spouses that they are caring for, and then women who have children, grandchildren, spouses to advocate and help care for them, to
Mhm.
bring them to their appointments, to follow up on their health, versus women of whatever income or socioeconomic status who don't have other people to advocate and care for them.
so we don't have data on either, and they're both important. So that's what I'm saying is, I think as a community, we need to say, what are the important things we really need to have in surveys or to have in data to understand women's, experiences with care, their access, their barriers and health outcomes. And those are really important factors. They all influence outcomes.
Because, for example, my mother and I, my mother is in long-term care now, and we were part of a study through Toronto Rehab and TFB on aging dementia from the older patient's viewpoint and the younger caregiver's viewpoint. And so we were both interviewed together and separately. And that kind of study on the supports that women have around them or that they are responsible for, I think, really crucial in just even getting to doctor's appointments and things like that.
Absolutely, and that's a whole issue around access. And actually what we did was, because the administrative data and the big quantitative data don't get a lot of that nuanced stuff. So actually, at the suggestion of our community stakeholders, we actually did for the Access to Care chapter, and a quick summary of it is in the introduction. We actually did a qualitative review, and we found out that we're actually 33 high-quality studies in the province, qualitative studies of barriers to care for all different groups of women, whether women with disabilities, older women, poor women, women with, homeless women, and to think about those kinds of nuances. So these indicators are kind of high level, that kind of, just gives you like there's something going on and there's something here we know is modifiable and we need to fix it. But to develop interventions and actually move these indicators, that's what you need to do, is really drill down and understand the dynamics behind all of them.
One thing you said I think at the beginning is strategically selecting the right, I think you said measure is important, or might even thinking intervention, because at the end of the day you said the best scenario was around the heart medication, how we all rose to the challenge. 99% of us are getting what we need if we have a heart attack. But then I'm thinking of my elderly client, and we do try to set clinical pathways when you're 85 and you have a dementia delirium, and nobody follows it. So then I'm struck with what it would be the best measure, because in fact you talk about patient-centered care and the importance of that, and because we come with so many comorbidities, and it's very tricky to say this is the right path. So I just think how you're going to go about selecting this right measure, I think is going to be very difficult in a way, right? Because it sort of depends on the patient sometimes what the best intervention will be for them. It's not clear-cut as this medication is going to save you. Do you kind of get what I'm saying?
Right. So can you talk a little bit more about, you say you give plans for dementia, and when you say nobody follows it, the patient...
So we try to create a clinical pathway, because all hospitals tell us what they should do on day 1, day 2, after a hip fracture.
Okay.
And so we work with geriatricians and say, okay, what do you expect? Advanced practice nurses, what should happen on day 2, day 3, day 4? Well, you know what? It kind of depends on the patient. So we do our best to say they should be up by day 2, but if there's a setback or they're really delirious, that's not going to happen. So in a way, we have so much variance that once you start getting clients, 50% of them aren't following a pathway, what's the point of a pathway? So I guess there's a small part of me that thinks it sounds like a great goal of selecting the right measure, but I think for our older population, it's not as easy as it sounds.
Right, and that's why I said the complexity in older adults makes it much more challenging. But that being said, one of the areas of the literature where there is a lot of evidence actually in terms of cost saving and reducing readmissions is in heart failure. Because there are evidence-based guidelines, there's diet, there's weighing yourself, there's getting the right meds, there's communication between the hospital and the community. So, and I think, there's also differences between process and outcome measures. And ideally what you want is an indicator cascade, right? So that if you want to reduce heart failure, then you can look and see, were they on the correct medications? Were they given the correct education, right? And in the aggregate, you might not do it for everybody, and there's always extenuating circumstances, but on a population level, can you reduce readmissions? And there's a lot of evidence for that. And actually, it's cost saving. It's not all quality interventions save money, but managing heart failure better because of the expense and the frequency of hospitalizations is one where things can be cost saving. So yeah, I think you need to target what things are movable and what things are not. And, and I think in terms of research, there really needs to be a lot more work done in terms of frail elders and what is the best way to optimize care. Chad Bolt, I guess, who's at Hopkins, has done a lot of work on glide paths and when they work and when they don't. But yeah, that's exactly where the research needs to go.
Anyone else?
Well, I can always go back. Ageism, which you touched on,
Right.
it's huge. It's certainly huge at St. Mike's and every other hospital that I know of, and have had brushes with friends, whatever. That's one of the underlying factors. And then financial incentives. There are financial disincentives for geriatricians because they're not paid like other professionals. And the disincentive for a solo family practitioner. I strongly support family health teams, but a solo practitioner, older people take too much time. So you combine the ageism and the financial disincentive, whether it's in the institution, first available bed, you're kicked out, which is not legal, but they do it anyway. There's a whole context there, and how do we get a best practices, or, well, there aren't, but good practices, and get the right information on what's happened to people once they've been discharged. You know, it's really hard, given that underlying context of ageism and sexism. Older women, well, they're not going to be energetic, they're not going to be able to do this. It's stereotypes.
No, you're absolutely right. I mean, there's a lot of education to do. My sense is that as the baby boomers, start hitting that, they're going to be much more, my sense is that baby boomers have made everything cool, so by the time they become old, it's going to be cool to be old. But I agree with you that ageism is a huge barrier to care, and especially I think there's an interaction between sex and age, and older women really, there's a lot of stereotyping that influences the type of care. And part of the things is by setting clear guidelines, it's not going to change everything, but by looking at the measures and being able to say, are people getting what they need and what is the reason for that? I think it's, part of my doing this is really to do this reporting. It's not that people didn't know that these weren't problems, but it's can we work with policymakers and providers and use this as a way of knowledge translation to say, this is a big, these are big issues, they impact on costs, they impact on hospital utilization, they impact on people's quality of lives. Let's have a conversation and see, what we can do to try to start tackling some of these things.
Good luck.
Yeah. Now it's up to everybody else. Everybody in this room, really. Okay, thank you.
Thank you.